if there is any data about planning an AVF access in patients suffering from polycystic kidney disease. Should we prefer SAVF from PAVF? She has just now write the questions in the chat. So for everyone, please feel free to open your microphone if you want to ask something, or you can do like Georgia did and write it down in the chat. So who can answer to this question?
You, yeah?
Please.
First, what do you mean by PAVF and SAVF?
I think probably surgical AVF or percutaneous AVF, I imagine.
Yes, that's right.
Surgical PVF.
Oh, I see. Okay.
Surgical and percutaneous.
Oh, I see. Well, in my country, we are just beginning with the percutaneous AVF, so I don't have much experience. But otherwise, I would take care of the polycystic kidney disease patients as of the other patients. So I don't see any significant difference. Although I know they are a little bit more prone to aneurysms.
But what's the point? The resident that makes this question, what's the aim of make this question in the context of the polycystic kidney disease? Because initially, shouldn't be a difference this kind of disease for the patient. Do you have some aim with this question?
I think because the polycystic kidney disease patients have a low diameter arteriovenous fistula, arteries and veins. So I think it's not possible to create an endo-AVF in these patients, because the criteria are many. The diameter of the perforating vein should be 2 millimeters. It is not easy to found in the patient with polycystic disease with these parameters, with diameters. I think the polycystic kidney disease patient, they have an arteriovenous fistula, a native arteriovenous fistula or distal, maybe with a microscope like Pirozzi, or I think we do the arteriovenous fistula in polycystic kidney patients.
Yeah, but
problem.
No, that's true, Carlos. But in any case, as you are going to say the patient depending on the mapping, with mapping,
of course, yes.
Sure, you have different probability depending on the chronic kidney disease, the theology of the patient. But as finally you are going to do the mapping of any patient in order to choose the decision, if you are going to do one thing or another, probably the origin of the kidney disease is depending. It's like diabetes, no? With mapping, you can select the indication. In fact, probably you have two kinds of endo-AVF approach.
Yeah.
One is if with ultrasound from the perforating vein going through the perforating vein to the artery below, and the other is through, you will check this, guys, and the other is through the or ulnar or radial artery, and with from distal or proximal, and with a guide wire in the satellite vein. And when you are close to the elbow, close the magnetos and make the fulguration in order to create the AVF. But in any case, it depends on the previous mapping, no?
Yeah. But the access is through the ulnar vein or the radial vein. 2 millimeters. I think it's not possible to in polycystic kidney disease patients to have 2 millimeters of diameter for introduce the material for performing an endo-arteriovenous fistula.
Mm-hmm.
So of course the mapping is important.